Good day. In this presentation, we will discuss how the HL7 fire standard can be used for healthcare insurance management. This presentation was made by the Standards and Interoperability Lab Asia or SIL-Asia with support from the Asian Development Bank. In the hospitals of today, patients expect that all information systems which concerns one's healthcare is readily available. This includes data on hospitals, laboratory, physicians, pharmacies. But not only clinical data, it also extends to social service insurance and payers. All data must be available, all systems must be interoperable. Interoperability is the ability of software systems to communicate and share data with one another. To make this happen, we need standards. Standards indicate how systems will communicate with one another. It documents the data formats, the communication protocols and data structures that should be shared by systems with one another. While government can set the standards, it will be wise for government to use internationally recognized standards. Why is this so? Because it will easily integrate with systems that are already in place right now. The HL7 International Group is a standards development organization founded in the 1980s. The goal of HL7 is to promote interoperability by producing a set of carefully crafted standards for digital communications of healthcare-related information systems. The name HL7 comes from Health Level 7. It pertains to the 7th level of the ISO communication model where HL7 is implemented. In this diagram we can see how the different standards are used in the whole ecosystem of healthcare information systems. And in many instances, HL7 is used as the key messaging standard. Even for billing on claims reimbursement, HL7 is being used as the data standard. There are many HL7 standards that have been used before. One of the early standards is the HL7v2 standard. This is a text-based standards that involves information being stored in text separated by pipes and carets. HL7 CDA and V3 are XML-based standards, where data is stored on XML documents characterized by object tags and attributes. HL7 CDA and V3 are XML-based standards, where data is stored on XML documents characterized by object tags and attributes. HL7 Fire, on the other hand, is the latest iteration of the HL7 standards, and the focus of Fire is on using RESTful APIs. In layman's terms, Fire utilizes the web and uses web technologies to facilitate the sharing of data across different applications. To further demonstrate the difference of the three standards, we can see the difference from having a text-based system to having something that's structured like HL7v3 or CDA to something where the data details are encapsulated to resources like HL7 Fire. In terms of usage, we can see that Fire is emerging as the most used standard right now. It is projected that in the next 5 to 10 years, the use of Fire will grow exponentially. Even top IT companies like Microsoft, Apple or Google are using HL7 Fire in their respective digital health systems. Fire enabled these applications to be developed quickly and enables health data to be shared easily. Countries all over the world are already starting to adopt the HL7 Fire standards. So now we are ready to discuss what Fire is. Fire stands for Fast, Healthcare, Interoperable, Resources. It's fast because it's fast to implement and it's easy to use. It's healthcare-based. Its goal is for health systems to be interoperable and it uses API resources. Fire is several things rolled into one. It can be a standard, it can be an implementation guide showing how APIs can be used in the local use cases. It can be a database schema, as it already presents the necessary structure for the various data to be considered. It can be an integration layer where all systems can connect, and it can be a terminology service interface. Given this multifaceted role of Fire, we can see that various types of users could use Fire in different ways. It can be used by developers, it can be used by clinicians. It can also be used by regulators and program implementers. The FHIR Manifesto is a set of 6 principles that govern the use of the FHIR standard. Focus on implementers. FHIR allows the developers to focus on the implementation by providing a set of resources that can model the whole digital health data exchange landscape. Follow the 80-20 principle. As a standard, FHIR is focused on covering 80% of digital health implementations while allowing the remaining 20% to be localized. FHIR also has a human-readable component where specifications are easily understandable and data in the APIs can be understood in an HTML format. FHIR also uses the latest industry-based web technologies. It uses RESTful API, which is widely used as of the moment. FHIR uses the Creative Commons license, implying that it is totally free to use. There is no fee that needs to be paid before FHIR is used. FHIR also supports multiple architecture paradigms. It can work for health facilities, for national implementations, or even for insurance providers. We are now ready to discuss the available FHIR resources for financial management. A resource is a data building block in FHIR. It is the foundation of the FHIR standard. As mentioned earlier, there are around 160 resources in FHIR. It covers a lot of possible data healthcare scenarios. The basic resources includes patient, practitioners, encounter, condition, procedure, medication, etc. Let's try to look at what is inside a FHIR resource. Let's look at the patient resource. The patient resources consists of several data elements like name, telecom, gender, and the likes. It is important to note that not all fields are required. Actually, only a very few number of fields is required, and if it is needed to add some data fields that are not covered by the core patient resource, then it is also possible to add new fields. Given a health-related use case, we can map its data element using FHIR resources. For example, if we will be working with Claim Form 4, we can see that its fields can be mapped to FHIR resources. Our interest should be the financial management module. The key resources in this module are payment notice, payment reconciliation, coverage, claim response, and explanation of benefits. The central resource here is the claim resource. If we inspect the claims resource, we can see that it has fields that are related to patient claims. The claims resource is connected to the patient resource since the premise is that a patient is the one making a claim. There is a concept of billable period in claims. The insurer is identified. The health provider is also related. There is a concept of funds reserved to determine the available claim that the patient can make. The care team, the health facility are also included in the claims resource. Even the qualification of the care team is indicated. Supporting documents related to the claim can also be included with. Patient diagnosis can also be specified. Patient insurance information can be indicated. The claims resource has a rich data structure of possible data that can be considered. It is important to note that, as mentioned earlier, not every field is a required field and that the resource can be extended to handle other fields. There are many use cases for the claims resource. It includes eligibility checking, patient enrollment, claims processing, submission of attachments, status check, payment notice, and request of explanation of benefits. Let's look at a sample use case. We have a patient that needs to receive healthcare from a facility. Inside the facility, he will be attended to by a doctor. These 3 objects use as the patient resource, the organization resource, and the practitioner resource. Together, they are under the encounter resource. Before leaving the facility, the patient can make a Philhealth claim by filling up Claim Form 1. As we can see, Claim Form 1 can be decomposed into multiple resources like patient location, telecom, eligibility, identifier, and even date time. Internally, the health facility fills up Claim Form 2, which will require the organization resource, the patient resource, the encounter resource, and the condition resource. We now look at some benefits with adopting FHIR. FHIR promotes the easy sharing of data. It allows EMRs to be integrated with hospital information systems, with billing, and even with employee records for a single patient. These can all be integrated to Philhealth systems. FHIR lessens the development time of applications. In the US, they recorded that before, applications took 4 to 5 months to finish, but with FHIR it was 2 to 3 weeks. By adopting international standards, more software systems can come in and be used by health facilities. UHC can be implemented faster, since if there are more interoperable applications, then the goals of UHC can be achieved. It is important to note that unlike other standards, FHIR combines clinical data with insurance and financial data. That's all for now. Thank you very much. Are there any questions?